This educational video was produced in cooperation with Royal Prince Alfred Hospital, Sydney, Australia, and its employees. The opinions, procedures, and patient care policies expressed or depicted in this videotape are those of Royal Prince Alfred Hospital and its employees, and do not necessarily reflect the opinions, policies, or recommendations of Boston Scientific Corporation or any of its employees. For further information and detailed instructions on the use of Boston Scientific Corporation's products, please refer to the instructions for use included with Boston Scientific product packages.
This 61-year-old woman had a Hartmann's procedure previously for metastatic breast cancer, and that was reversed, and she's now got a malignant stricture at the site of the Hartmann's rear anastomosis, causing an extrinsic compression of the bowel. And here we see a guide wire going through the stricture. So the stricture is at approximately 10 centimetres from the anal verge, and the guide wire can be seen going into it.
An ERCP catheter was placed over the JAG wire, allowing an initial contrast study. This showed a normal proximal colon, the top of the stricture, and the length of the stricture. The 5 centimetre radio-opaque tip of the JAG wire can be used as a measurement device. The Boston Scientific Ultraflex Precision Colonic stent was used. This is a self-expanding nitinol stent. The JAG wire is inserted into the stent delivery device. The stent is then well lubricated, and the apparatus is placed through the anus and into the stricture. A 9 centimetre stent was used, which has a 25 mm main body and a 30 mm proximal flare. And the stent is positioned across the stricture using the post-deployment markers to aid positioning. It has a high tensile suture release system . After the stent is fully deployed, the delivery apparatus is removed and a post-contrast study performed. A second contrast study showed the proximal margin of the stricture and the stent, which had begun to self-expand. However, there was a further 1 to 2 centimetres of proximal stricture which was not covered by the first stent, which required a second stent to be placed within the first. The second stent was 6 centimetres long and also had a 25 mm main body and a 30 mm proximal flare. I positioned the second stent so that the proximal marker was within the distal flare of the first stent. post-deployment contrast study was performed and showed the 6 cm proximal stent within the 9 cm distal stent. There was also good proximal inflow demonstrated and distal runoff. A colonoscopic view through the stent allowed visualization of the normal proximal colonic lumen. A postoperative abdominal X-ray showed the final position of 2 well-placed stents. The immediate results were gratifying.